All right, so I'll email you guys a copy. It doesn't look like it. Let me upload directly. That's okay. I'm going to turn it over to Dr. Doug Hasbrook.
So is that what's going to be on this screen? I'll be able to see, and if I want to show the.
Yeah, you just switch the screen right here.
Okay. Okay.
Let's go ahead and bring that up real quick, just so you got it.
Okay. And my mic is on, I guess.
Looks like it's good.
Okay. All righty. Okay. So there it is. Can everybody see me and hear me? Yep. Okay.
Yes. Good
Thank
morning.
you. Good morning. So this is obviously we're in strange times. So I've done this for Aaron for about 4 years now, and so I've interacted with I don't know, 4, 5, 6 different groups of students in the same situation that you're in. So I have you know, some sense of what you're learning, and have had dialogue and interaction with students in your situation for a while. So I think that gives me some confidence. And so my session today is really focused on just discussing aspects of interdisciplinary interactions with I'm an MD by training, so with the MD based what we call allopathic medical culture. So Aaron has had me come to do this work because I've been a yoga practitioner about 18 years now. I have a regular practice. I practice at Mountain Yoga Sandy with Alex and Jackie Wheeler down there. I would say my yoga practice started out primarily as a physical practice, and through that practice, I've acquired more the meditative aspects of the practice. I don't have a strong sitting practice, but I have I feel like I do pretty well coming into the meditative space through yoga in motion. I also have, I'm an MD by training. I went to the University of Minnesota Medical School and graduated from there in 1981. So I've been in the healthcare space for quite a long time. Started medical school in '77, started interacting with patients in '79. So I feel like my experience in patient I get clumsy with various words, but patient, I'll use for now the patient-physician relationship. which broadens to patient, healer relationships or whatever language we choose. So I've had I've practiced in quite a few different situations, from county hospitals in an urban setting to I practiced on the Navajo reservation in northern Arizona for 2 years, in Kayenta below Monument Valley. So I had that that cultural experience. I've practiced in West Valley here in the city for quite a few years, and then I practiced with the University of Utah group and the Greenwood Center, which is down in the Murray Midvale area. And then I've also had the background of being an administrator in the healthcare system, working with health insurance systems. I had retired from working about 1.5 years ago, and but 2 weeks ago I got a call from the university health system to asking me to come back to work again on a temporary basis with the health plan, because the medical director that was doing that work had been called back to the university hospital to help with their crisis planning situation. So I started back to work again, and I'm in the thick of it. So I guess that's enough of just kind of background. I guess the other thing I'd say, and part of the way Aaron knows me, is that besides yoga, I've had an interest in alternative, or what word do we use rather than alternative? Complementary, that's the word. I've got to get back into my language. Alternative or complementary practices, not doing them by myself, but engaging with others, quite a bit in kind of we call it the shamanistic space, that nature healing wisdom. So that's me. And so I guess I'm trying to communicate that I have this traditional science-based training and practice. I'm also a bit of a skeptic of that. I mean, I feel like I'm aware of the limitations of that system of care, of approach to healing. I'm just going to use that word. So a part of the discussion today is, from my perspective, the path that you're on, just thinking conceptually about the path that you're on. With in recent groups that I've taught or been able to speak to, I think at the end of it, what people, the feedback that I get after I've given these discussions, so I want to give you a sense of what people seem to get from this dialogue or this conversation. It's less of a dialogue today. When I'm in the room with you, it's easier to get a sense of what people are thinking or may want to say something. I'll try to do that today. But the sense that I get is that people, it causes people to think a little bit more about where am I going with this training, and how might I use this training? Because Aaron, these are first just beginning.
Probably their second month.
Second month, right? Okay. Yeah. So most of the people that have been in my sessions in the past have strong yoga practices. Many are yoga teachers. Some have clinical backgrounds. But the strongest, the majority of people, I think, have been more on the teacher side. I don't know if I can get any. So everybody can still hear me, okay? Is that right? Yeah.
Yes.
Okay. I don't know. I'm going to ask people to. Anybody that's has clinical training, like a nurse or a therapist, social worker, any of those things. How many? Just give me a sense of any of you that have that.
I was a behaviorist for the state, an autism specialist.
Okay.
I worked with a lot of therapists in the work with autism.
Okay. Anybody else? Okay, so I'm assuming most of you then the background is as yoga teacher. Does anybody have something besides yoga teacher that they've been doing? Okay.
I'm a personal trainer and exercise physiologist.
Okay, so that's been your okay. So that's been your aspect of the physical interaction with people then. Mm-hmm. Okay. So a part of what I like to start out with in this is so I'm going to put this. Do you see the Word document, or do I need to click on it? I think. So
I think you need to go to share screen.
Okay. Is that up now or no?
So if you go to the bottom part and you hit share, and then you have to double click on what you want to share.
Okay. So let me do this. So share screen. Okay, I see that. Okay. And then there it is. Okay. Can you see that?
Sure can.
Awesome. Thanks, you guys. So.
No, this was shared on email yesterday evening, so we do have a copy.
Oh, you do have it. Okay.
Yeah.
So if you have this, then I'm going to not have it be up. Is that okay with everybody?
Yes.
Okay. Okay, I'm going to stop share then. Okay, because this way I can kind of see what's going on. Yeah, so why don't you grab that handout? And again, so you folks are on a path that has been less of a client-based path and more of a teacher-based path. So I'm just going to make that broad statement. It may not apply to all of you. But I think a piece of what I hope comes from the session today is, okay, I've decided to get this yoga therapy training. It's a new field, so you folks are creating this field. There's obviously been some pathfinders before you. I mean, this school has been going on for several years. Like I said, I've been interacting for 4 years. But I still, my belief is that you're still creating what this field is. You know, just at a pure conceptual level, there's obviously lots of ways that you can apply this learning. I mean, one way would be you're just trying to understand your own yoga path more thoroughly, and by you know, through this training, perhaps continuing to teach yoga or continuing in like the personal trainer type relationship, and just have that be enhanced through this training. You know, other people have applied it in a bit more of a what I would call a clinical type environment. You know, some people being in like pain management settings, pain management clinics, oncology clinics, substance abuse clinics, you know, substance abuse rehab clinics, supporting psychologists, so the, you know, behavioral settings. So there's lots of ways that yoga therapists, you know, use their training. And a part of what I'm hoping to stimulate, maybe some of you have just like, I know exactly what I'm going to do with this training. I've already got a business plan. Okay. That's from Aaron. And I am all set and I know what I'm doing. My experience with prior classes has been maybe 25% have a pretty good idea how they're going to apply their learning, and 75% are more in the, you know, are just exploring as they go along, I guess is how I'll put it. So I guess as we're talking today, I think for you to put it in a context of this training is something that I'm going to manifest an activity or a vocation that includes this training. So that's the frame. And so, you know, the school uses, you know, has the philosophy of that you'll use your training in an interdisciplinary fashion. And by interdisciplinary, meaning collaborating with people of other training backgrounds. And interdisciplinary, to me, the inter part means, you know, versus multidisciplinary. The interdisciplinary to me means oftentimes engaging with people of other disciplines and focused on one person. Like one person you might be interacting with, but you understand that maybe they're seeing a psychologist, or maybe they're seeing a massage therapist, or seeing an MD for an issue, or a nurse practitioner for an issue. So that's how I'm thinking about interdisciplinary. And so my piece in particular is, you know, thinking about interfacing with the allopathic world, or the science world, you know, which is kind of our dominant system in the Western culture at this point. And, you know, just like, you know, what kind of, again, concepts, you know, I'm just going to talk about some core concepts of how we all think about things and how we use words. So let's start from this, at the top of this, the whole thing of, you know, basic definitions. And, you know, so definition of health. So this is just like strict dictionary definitions. State of being free from illness or injury. Wellness, state of being in good physical and mental health. Disease, a disorder of structure or function that produces specific signs or symptoms. Illness, an unhealthy condition of body or mind. So I'm going to just make a couple of comments, and then maybe if one or two of you would be willing to share your reactions to these words and these definitions, because, you know, as I just like the word health, state of being free from illness or injury, it's just interesting to me that it's trying to define a state that by the absence of other things. You know, it's not like a positive assertion. It's the absence of these bad things is what this good thing is. You know, wellness, state of being in good physical and mental health. So anybody just, is anybody willing to just react to those definitions and what's your thoughts of how you think about those words of health and wellness, disease and illness?
My brain is trying to form it in a positive sense, and I'm struggling to come back to original state, but then people are born with lacking health. So I'm having a hard time trying to find a definition that doesn't include
Yeah, the
illness
lack.
or the
When you
lack
say
of-
people are born lacking health, speak about that just a little bit. I'm interested in that.
kids that are born and put on life support immediately,
Oh,
or
right.
have heart issues, brain injuries, cognitive disabilities. I think there could be you could go down a rabbit
Yeah.
hole there.
Okay, but that's how so what you're saying is that some people are born lacking health.
Right. And that was my original thought, was like, well, come to our original state
Yeah, okay.
with that.
Okay, I understand now how you're saying that. Anybody else have a comment they'd be willing to share? I don't know how many people I have on here. Are you guys able to tell?
There's 14 of us.
Oh, okay. I thought there was quite a few. I don't have the whole screen going.
They just seem like really basic, really simple definitions to me.
So, but then tell me just try to, I personally think it's kind of, you know, we use these words all the time, but then when you start to think about it, like, well, what do I really mean by this? So take a shot at, you know, just what concepts come to your mind if you think about health and wellness?
Well, like the definition for health, I think this is the definition of like good health. But you could be in like your state of health can be like, there's a whole spectrum.
Right. So what about the wellness statement, the state of being in good physical and mental health? Does anybody want to add anything to that?
Back to the health and wellness, maybe thriving in your environment. Therefore, like, it doesn't necessarily define an illness or lack of illness, but that you are thriving. And that, I mean, someone could be born with a heart defect, but still thriving and have illness.
So that's good. I think this discussion has kind of gotten me to where I want to go next, which is I think it gets to the core of so, you know, if I trained as an MD and got certain knowledge and skills, you know, like what was it I thought I was going to do with those skills? And I think for you all to think about, you know, and maybe you think this is self-evident. I've been doing this a long time, and I don't think it's self-evident. I think it's important for anybody going towards particularly an individual therapeutic relationship with people, that they are really clear on what is it they're trying to do. You know, why are they engaged with that person? And a piece of that is because it's very easy to get very reactive. You know, so say you get certain training and have maybe some vague ideas about what you want to do, and you're taught, you're taught techniques. I mean, it's I think most of these skills have certain technical aspects to them. Like the technical aspects of my training is, using pharmaceutical compounds, how do they affect, certain measurements of lab, data, et cetera. You learn techniques of asana, assessment of alignment, techniques of meditation training. So you learn these technical skills, and then you start to encounter people that may have a vague idea of what they think you know, or and what they think you're doing, and what they think you want to do, and suddenly they're saying, "Help me with this." And if you haven't really thought about what it is you're intending to accomplish, pretty soon you're reacting to them. So that's what I mean by reactionary. It's like, yeah, it's just, so I think if you can, as you're going through your training, to keep in the back of your mind this concept of what is it I think that I want to do with this training. And that's why I guess I start with these words of health and wellness, disease and illness. Are you, I mean, so for me as an MD, the things that an MD is trained for are also the things that we're criticized for, because I mean, typically people are coming to us, hurting in some way. I mean, they don't feel good. They're in pain. They're function. Maybe they just were in an automobile accident. They're having a heart attack. They're bleeding from their intestines. They're coming with something, sometimes dramatic, sometimes not, sometimes subtle. But so the definition of health, state of being free from illness or injury, that kind of limited in a negative sense definition, probably does apply to most of what I've been trained to do. But because of that focus on trying to correct or cure that immediate presenting issue, the criticism, which I think is a valid criticism, is that then we ignore the whole person. We get focused on the body parts. We don't see the person as a whole. We don't take into account other aspects of their life besides their physical life. So we're treating people like machines, like a mechanic. That's the criticism of, it's the weakness of the allopathic system. I'll come back to that a bit more. because I do like to think about the strengths and weaknesses of various approaches to encountering human maladies. So with me having talked a bit about my skill, my technical training, and how that relates to these words of health, wellness, disease, and illness, I wonder if one or two of you could say something about, how you're thinking about this, your reason for coming into this training that you're in, and what you imagine you're going to be trying to do. So if I say, what I was trained to do is, primarily, I mean, it's broader than this. I'm speaking in just generalizations for the purpose of having the discussion. If I say, I was trained to be sure somebody didn't die when they came in with a heart attack, to be exaggerated about it. A couple of you one or two could say something about what you think you're wanting to do with your training.
I will go.
Okay, Jenny?
I am thinking that one of the main things that I want to do is work with mothers postpartum and help them come back to themselves and release anxiety, and maybe work with them with postpartum depression and just all the overwhelm that comes with being a new mom. I was a mom. I have 2 small babies, and so I went through all those things. And so that's, I think, what I want to be. One of my main focuses is making courses for them and working with postpartum mothers.
Very nice. So what I'm hearing a little bit, so that's that is restorative in some way. I mean, is that what you think? It's like a restorative engagement?
Yeah, I think it would be, like a restored. Yeah, that's a good definition of it.
Okay. Because it's acknowledging that transition, that transition of being, pregnant, mother, delivery, child, that's a transition that person is going through that has a whole set of scenarios around it, and understanding the physical, emotional, spiritual aspects of all of that, trying to intermediate in a way that their being is optimized or enhanced, right?
Yeah, yes, exactly. And lots of moms go through birth trauma. And I think that that's not talked about a lot in our society. And so that's one of the trauma aspects that I want to help mothers, because I think a lot of mothers block out birth trauma and think that they might not even have that, when really they had a really challenging birth or postpartum experience. So yeah.
Okay. Thanks for that. Is there one other person that would just say a little something about what they're thinking about? Laura?
Yeah, I can go. So I'm also like a health coach, and I'm a certified eating psychology coach. And so I end up working with a lot of folks with just eating challenges. And usually that's brought on by some sort of past trauma. And so in my opinion, yoga's just been really helpful dealing with all those things.
And when you're talking, so when you're using the word yoga, what aspects of that do you come to your mind?
Really just like coming together in a group, like community has been really powerful. And just like the way it, practicing physical poses can just really help somebody's confidence and self-love.
Okay. So because you're on, I'm going to ask you this, but it's a more generic question, but just I have you on the spot. As I think about yoga, I think about it kind of in the physical, the meditative, which I guess I think is like emotional, maybe mental health kind of thing. And then I think about, spiritual. So I kind of think those three planes. With other groups, everybody basically the physical piece. And then I like what you're saying about the community, which is probably a fourth domain. And then some people are like, the mental health side, I'm not as, or behavioral, I'm more the physical. And then even a smaller subset will say, I don't plan to, dabble in the mystical. So tell me what your thinking is.
Well, I really enjoy all those aspects.
Okay.
I mean, for sure, most people get started on the physical aspect. I mean, that's what kind of sparks everyone's interest. Like, oh, I've heard I should do yoga because it's, it'll help calm my mind. And so that's usually what brings people in.
Yeah.
So definitely I'm more of a physical person as well.
Yeah. So I thank you for that. I like to bring that out because I think, again, it's part of each individual thinking about how they're intending to apply this training. Some people can say, I'm just going to do the physical, because maybe just individual sessions, just physical. Then to the physical communal, do it in groups because of the sharing aspects, the energetic sharing. Other people, some people, it's like almost pure, just the meditation, piece, but meditation in a non-mystical sense, just meditation for the purposes of living this physical life. And then other people, really, want to be more on the spiritual side. So each one of you, that would be, unique to each one of you. But again, is the thing of trying to think about that as you go along, so that you're not, again, just reacting to the people that come to you. I think that as you start a practice or a business, start to use these this training as a real world activity, moving from student to practitioner. Again, particularly when you're starting out. I mean, especially if you're starting out and it's kind of like, I want to make, all of us do activity, the whole thing of money. If we're, subsets of people are fortunate enough that they maybe can spend their time and, it's great. They can just give their time away. But, if you move towards I'll just say a business of this, just the pressure of, if you rent a space or whatever, or you have bills to pay, the whole thing of, oh, this person's coming to me with this kind of thing, that really wasn't what I was planning to do, but they like me and they've got this issue, so I'll start to work with them. And then that person says, oh, this person, my yoga therapist is great, help me with this. And then all of a sudden you have a bunch of people that you're working with, that you're doing something that you really never wanted to do. So, then a year or two down the line, it's like, oh, what did I get myself into? So again, that's part of what I'm trying to just frame up for y'all. I remember the first time that I did this training, it was actually with people in their second year, the second part of their training. And so they had gone through a lot of training, and I was talking with them about this, and I'd say at least half or more still hadn't really thought about what I'm talking about. Like, oh, geez, yeah, how am I going to use this? And why did I come into this myself? And I'm not laughing at them. I mean, I think that's I went to medical school. I had no idea what I was getting into. I was 21 years old and I was good at science, so I went into medical school, and it's been fine. Anyway, so I'm just this is part of I'm trying to help you understand why I'm here talking to you today. Because anyways, so I'm going to go into, so the next few things is allopathic medicine. Foundation is scientific method, evidence-based, based on proof, mechanistic, categorical, by like disease state and body part, focus on symptom complex and a body part. And then I'm going to read, alternative complementary medicine. Foundation is meeting the patient where they are, often based on older traditions. Emphasis on holistic approaches, prevention, and meeting the patient on a more individualized basis. And then the next one, aspects of health, wellness, physical, psychological, spiritual, we talked through that. In terms of that allopathic versus complementary dyad or duality that I've created there, anything that anybody want to say what I've missed in terms of how you think about, those opposites or differences on a spectrum?
Well, I agree that I think you posed it here as a duality, and I guess I think of it as more of a spectrum or a range. In particular, because my training is as a social worker, but not clinical, and I'm a researcher, I don't want to see evidence-based as belonging only to allopathic, because I do think there is an evidence-based coming out of practice along the entire spectrum. So anyway, so I do think of, for me, it's more helpful to think about allopathic and alternative as being on a spectrum with a lot of overlapping areas. I mean, they're like yourself, you're allopathic, but you have alternative practices that you incorporate. And I think even for some allopathic physicians, like the really good ones, you understand the art of the practice, not just the science of it. And I think, on the other hand, for complementary practitioners, there's a great deal of thinking about the science that goes into the art of the practice. I guess that's what comes up for me.
I love that. Thank you for sharing that. That's great. Anybody else have a thought they'd like to share? So I'm going to build on that because you captured some things that I think about as well. Is there's as you say, you like to think of it as a spectrum, and I'm with you on that. Although it's really interesting, it's just interesting to me. Well, so I'll just go this way. There's clearly allopathic scientific trained people that they won't even talk about, think about, interact with, anything complementary, alternative. They're just like, if it's not, if it can't be measured, I'm going to start with the extremes and then move into more of the discussion. But you know, like if it can't be proven, it's quackery, it's fake, whatever. And then there's people on the complementary side that that really resist. I mean, and I don't know what the I don't know what the I don't have a sense of how much this has changed, but there's people on the complementary side that really resist any attempt to measure and classify the type of work that you're doing, their work. Their foundation is on the ancient lineages and on the ancient teachings and teacher-to-teacher transmission of knowledge, and believe that the power of the tradition is in the engagement and interaction itself, and any attempt to measure it or quantify it destroys the energy. And so I agree, and I read and I see a more evidence-based approach to yoga therapy, and with different categories of people presenting, like back pain, chronic pain, fatigue, depression, anxiety, having a description of this group of people presented with these types of issues. We place them into this therapeutic setting that includes the technical skills that you're learning in yoga therapy, and the group that received those additional technical skills had superior outcomes to people that didn't. So that's the evidence-based part. And so I guess I just need to say, or just state, and that seeing things that way is still as controversial. I mean, and that's why I started out saying, the path that you're on. Aaron's not in here, so I don't know how he could tell me how long this distinct notion of a yoga therapist has been around. Maybe maybe one of you. Does anybody have a sense, like, how long has?
I can't give you the source, but I was just reading that an article that had cited that it was, and they had the source behind it, that it was over 100 years old.
Really? Okay.
Yeah.
Okay.
And going back to what you were just talking about, like, don't you find that they're overlapping, that science-based medicine is starting to overlap with ancient medicine? So I was reading a research article from Cleveland Clinic, and they were talking about the just doing simple breath work with their patients, and it wasn't yogic breathing, and it decreased lung and heart issues, and the issues, I don't remember the medical diagnosis that they had, but I find that they're just overlapping, and science is proving what ancient knowledge has already been saying.
Yep.
I would totally agree with that, because I know I did my graduate work at the University of Wisconsin back in the late 80s. And back then they were actually starting to do MRIs on the voluntary group of Buddhist monks, and showing that what happens in the brain during meditation. And so the evidence base for mindfulness and meditation has grown tremendously in the last few decades. And so I agree with, go close, Kathleen, what Kathleen was saying. Sorry, the names are really tiny. But what Kathleen was saying about, I think slowly, as our methods get better in science and our interest grows in finding ways to help people be healthy, to achieve wellness, to maintain wellness, as our methods improve, we're starting to look at how do we understand what this is doing in the mind and the body. And I think there's more mind-body bridging that's going on, both in clinical therapy work as well as in um, physical medicine. So I think the difficulty is that science is sort of slow. And science is particularly slow to catch up to, unfortunately, um, to catch up to studying things that quote unquote cannot be patented, that cannot be put out and commodified on the market in capitalism. Because, for example, there's a rafter of evidence about very simple things one can do to lower, for example, risk of cancer, particularly in women who risk of breast cancer. And how do I know this? Because I'm a survivor and I read all the research. But they don't want to particularly fund that kind of research because you can't put a patent on eat a mushroom a day or eat broccoli or a bunch of other things, drink matcha green tea and many other things that actually have been proven to lower risk and do it much better than some of the pharmaceuticals. But a lot of the funders aren't interested in doing that kind of work because you can't put a patent on broccoli. And so that's why science, in some ways, the funding mechanisms for science make it slower to study something like mindfulness, except you can put a patent on a certain kind of mindfulness, so that's been okay, right? So anyway, just kind of putting that out there.
Yeah. So we'll, as we talk, we'll come more into what you're saying, or some of the points that you brought up. I want to just ask the question if there's anybody in the group that's courageous enough. Well, number one, you have to present it as this is your stance, your belief, and if you're courageous enough to say the idea of trying to quantify the effects of what I'm learning, I'm opposed to. Is there any? And there doesn't have to be anybody, but usually there is somebody. So.
Can I interject something though?
Okay.
So you're saying quantify, and not all research has to quantify it. Not all science has to quantify the effect. There's a great deal of research, happens to be what I engage in, that aims for deeper understanding rather than quantifying.
Yeah, but I guess when I use the word here, so this is good because I mean, so much of this is about language.
Yeah.
Yeah. So when I use the word quantify, I guess what I'm saying, because to me, if we're saying there's evidence of something, it means you're always having to contrast, like these people did with this situation did this, and these people with this same situation did that, and this one got better and these got worse or stayed the same. So it's a comparative trial of some sort. It can be, it doesn't have to be placebo controlled. It doesn't have to be double blinded, but at a minimum, it's got to be somewhat observational and comparing like to like. And so when I use the word quantify, I'm using, because that requires a degree of discipline and measurement.
So I would argue it doesn't necessarily require measurement. I think measurement is part of the picture, but I would argue that achieving a deeper understanding can be done in many ways. So what you're talking about really is an aspect of research that is intervention-based research, which does tend to be more quantitative than anything else. But even the intervention researchers today are finding out that if you've done, an RCT, a randomized control trial, and you have this intervention versus that intervention versus zero intervention, and you look at what are the outcomes, let's say they're aiming for quote unquote recovery. Well, they may show that this helps intervention A, more people achieved recovery, so to speak, however they're measuring it, however they're understanding it and defining it, than in the other two groups. What they don't know, though, still, is exactly what is the experience of recovery and how do people understand recovery.
Yeah, but so I think you're getting at what I'm talking about, though, which is, so parts of what you were just talking about were quantification type ways of thinking about it. And then the other part was a non-quantification way of thinking about it. And so some people that I meet and either in these classes or just, out and about, say, I'm only interested in the non-quantifying side of this. Kathleen, I think it looks
I
like
think there's a big difference in yoga therapy versus being a practitioner and a spiritual practitioner and practicing the lineage that interests you in yoga versus a treatment method for an illness. And I think that's what differs from, I'm a practitioner and I wouldn't measure my meditation. I don't track my meditation because I don't meditate to track it to have a certain amount of days. I track it because it's a practice that is spiritual to me. The yoga therapy that I do with clients or the yoga privates that I do, I measure that because by trade, I'm a behaviorist, and I believe that whatever intervention I put in place, I should know if it's working or not working. And those are two different sides of the same coin, I guess.
Yeah. So that's good. This discussion has brought out exactly what I wanted to just have us all think about. Because there's not a right, I mean, this is on a spectrum, and there's not a right answer from my point of view. I think, again, I'm asking you, each one of you, to think for yourself, how do I think about this? And I think it becomes, I think a part of the reason for me to have this dialogue is because I think it's mostly because of the interdisciplinary aspects. Because if, depending on how you want to interact with other people with other training, kind of knowing your bias, I'll use biases or just your ideology and your philosophical stance. I'm not trying to use any of these words in pejorative ways, just the basis for your personal basis for taking an action. Like I got this training, I'm taking action, and to really understand the basis of that, and the thing, because it happens less and less all the time, but really tense conflict between allopathic, so one person with an issue seeing a complementary practitioner and seeing an allopathic practitioner, and the person themselves is hoping that they can get input and the benefit of both of the people they're dealing with, and but something comes up that the practitioners get into this battle because of these philosophical positions that they may or may not even be conscious that they have. So again, this whole questioning and trying self-understanding is why I'm here today. So I've been talking, I think, for about an hour. Do people want to take a 5-minute break for themselves to stretch their legs and get a glass of water or restroom break or anything? Or okay, I see a couple of yeses. So let's take, let's see, it's 12:41, so let's be back around 12:45 or so, and I'll start up again. Okay. How do I turn off the?
Don't worry about it. I'll just use it.
Okay. Am I on again?
You are on. You wanna be closer? or-
No, I'm good. And is, because I like to be able to kind of see what I'm, and how do I tell if everybody else is on?
Are you guys? Oh, they're on. Good.
Okay. So
I'm
they-
back.
Go ahead and start.
We'll do that timer. That seems to help people.
Okay.
You guys see the timer?
It's not on there now, but it was on the screen, yeah.
All right.
Okay, so I just was talking with Aaron about, so I'm going to plan to go till, I'm going to plan to go another 45 minutes, take another short break, and then go till about 2:15. Okay, so that'll be my process today. So is everybody, has anybody had a close family member that has come down with this COVID virus? I'm just curious.
My husband has it.
Really?
He's deployed right now in Germany, and he's in quarantine.
Wow. How's he doing?
He's doing really well. He's on like day 10 of his
Okay.
quarantine, but he had really mild symptoms.
Did he? Okay.
Mhm.
Yeah. It's the whole thing of the health consequences of this, and then the economic hardship of the social distancing. It's like, which one is worse? I was just telling Aaron, I was talking to I have a friend who lives in northern Italy, and between Milan and Bologna, which is where the so somebody else said my sister and her family had it in Brazil. My 23-year-old nephew currently has it the worst. Wow. Yeah, so I just think the social the social distancing, it's so hard, but I mean, the pace of the outbreak without the social distancing is what Italy and Spain are experiencing, and it's pretty devastating. So I'm glad we're here talking about wellness. So I'm going to just talk then. We're going to move to this. Well, I'm going to just mention placebo. Just so we've talked about health wellness. We've talked about various aspects of why we would do the things we're learning to do. The whole thing of, can you quantify, and what does quantification mean? So I want to just throw out the word placebo. So the definition I have here is a substance or treatment of no intended therapeutic value. In a clinical trial, any change in the placebo group is known as the placebo response. The difference between the placebo response and the no treatment group, and the treatment group, that's a typo. The difference between the placebo response and the treatment group is known as the placebo effect. And I like to just have that word out there. Again, it's always funny to me in these classes. Sometimes people have a strong negative reaction to the word placebo, and then other times everybody's like, "Oh, placebo effect, that's cool." I don't have a problem with that word, because I guess again, I'm older, so I think the whole thing of something that can't be measured, again, going back to this measurement thing, the placebo effect can sometimes imply, oh, that's all in your head, or that's not valid, or somehow you've been tricked, or like the whole thing of, is it magic? And so, in my mind, so I like to use this example. The class of drugs that are called SSRIs that are used for the treatment of depression, in many controlled trials, by controlled meaning placebo. So they produce a pill that looks exactly the same. One has the active compound, one does not, so that the practitioner and the individual don't know if they're getting an active ingredient or not. And they're in any other context, whatever normal therapy was besides giving the substance, 25 to 30% of the people in the placebo group would improve to the same degree as 30 to 40% of the people in the treatment group. So just say 25% improved in placebo and 35% improved with the drug. Some of that can just be the normal course of the disease, but still that 25% improvement is more significant than most folks that are outside of a trial. So just the interaction with the system has an impact. So in some ways, I guess I think that the placebo effect is, shows the power. But we put all this importance on giving that drug, and I'm not telling people that the drugs don't help and as a part of a therapeutic intervention, but I do think it's important to realize that there's aspects to healing that we just don't understand. Just that whole thing of the unknown. What allows some people to heal and what and why don't other people heal, or move towards a more normalized state or a more optimal state. And so I think that in my mind, and this was discussed earlier, just the whole thing of, what we don't know. And because some of what we don't know, I think is, maybe it's just that the sophistication of our measurement isn't detailed enough. But, so there's the other, I guess, piece of this, because I'm trying to lay out here the whole, just thinking about, what is it that you do? How does it compare to what other people do? The kind of dialogue. How do you present what you do? And I think about it this way. There's the whole thing of chronic pain. We know chronic pain is a huge issue. Part of it, because of physical things like trauma and physical trauma, and some of it being, contained in a context of psychological trauma that can amplify things. But we've used allopathic medicine has used the opioids, as their approach to, this class of issues. And, we've got a huge opioid epidemic. So, if the allopathic world has everything all wrapped up and we know what to do to move everybody towards healing, clearly we wouldn't have this opioid epidemic. So now we're struggling with pulling back on opioids, and now the underlying root of pain is still there. So as I talk to fellow allopathic practitioners, and I think again, people are getting on the allopathic side are getting more and more enlightened about the gap in so I like to look for these gaps. And I'm going to go into next a little bit of, the phases of healing and what allopathic medicine has been focused on. And, through that discussion, just reveal this whole thing of these gaps. Because again, going back to the primary reason for this discussion is really two things. One is, what do you want to focus on yourself with your interventions? Because I'm pretty sure that you're not planning to be use this training to be an MD. You're focused on these gaps. I just call that out, like things that people are, areas of issues that are not being solved by the current system. And when I say this system, I'm actually saying that really broadly, like, okay, it's not being addressed adequately by the current, allopathic system, psychiatric, psychologic, social work system. There's many people in complementary practices that are doing things that they've done, and still these gaps remain. So I think for all of us to be humble and realize that there are these gaps, and to as you're being trained to think about, it's like, I like Jenny's comment, about where she's thinking about going. She's thinking about going into an area that's maybe not optimally served. So I'm just going to go through this phases of injury healing. That's the next little bullet point there. So acute, subacute, and chronic. And so I'm giving you in these definitions the classic medical school definitions of these words. So acute meaning sudden onset with the episode lasting up to 6 weeks. And so, well, I'll just go through all three and then discuss it a bit more. So subacute is more the healing phase, generally 6 weeks to 6 months. And then chronic, symptoms, conditions, and or disability lasting greater than 6 months. Now, some of this might be, in terms of these timeframes, might be a little bit arbitrary, but I think they actually do have a basis in physiology. And what I mean by that is, and sometimes with the second year people, I go into some of the more like acute inflammation and healing and a little bit of physiology that goes, at more the cellular chemical level. But, just from practical experience, you can understand, if you slice your skin with a knife, so that's the acute insult, is that injury. And then a whole reaction of the body starts to happen. The walling off, inflammatory healing aspects that basically try to just create integrity, put a scab on that wound, protect it. And if it's, and even with stitches or whatever, at 6 weeks, typically, usually with an incision, depending on the size, et cetera, say you get stitches, those are going to come out in 7 to 10 days, but you would notice that it's still red, and you're going to be advised, take it easy with that, because, for like 6 weeks or so, because at a cellular level, if you look at that, you'll still see healing cells coming in there, and you'll see what we call fibroblasts, which are laying down doing the knitting, so to speak, knitting things back together. and that and most of that, and again, at the physiological, microscopic level, there's different cell types, and some are more prominent in that acute healing part. And that whole phenomenon tends to last about 6 weeks. And the 6 weeks to 6 months, that wound will continue to strengthen. And, you'll even notice it that the scar is more red or pink early on, and then it, turns to white. So, the pinkness is because there's still more blood flow going there. The healing is still happening. And at about 6 months, something that's going to, at 6 months, typically the vast majority of that healing process has occurred from an acute injury. Beyond 6 months, if there's tissue damage to the extent that, the motion is changed, a nerve damage has been done. We think nerve healing can take up to a year, but things that are residual beyond 6 months are thought of as, well, this is a persisting problem. So the whole thing of chronic meaning persisting. So again, we can argue with the exact time frames, but for typically you're going to likely, as you're in your training with the school here, they'll say to you, acute injuries, like in the first 6 weeks, you probably don't want to do very much. I mean, because you might worsen the injury because it's too fresh. In the subacute where things have started to heal, to be more gentle, but to be aware that a healing process is still going on. And then the chronic phase, I partly emphasize that because these gaps that I was mentioning tend to be more in this chronic bundle. This is where I go into a little bit of history of allopathic medicine to give you my perspective on why we have the system that we do, that we like parts of it, but parts of it are dysfunctional. And there's obviously lots and lots of reasons, like, the capitalistic system and the patents and all that kind of stuff. But I'm going to stay at a more basic level than that. So one thing that I like to bring out is that this study of endeavor that we think of as modern allopathic medicine is really only about 100 years old. So there's a book that was written by, I'm going blank on his name now, but it was written in the 90s. And the fellow who, it's called Medicine, the Youngest Science. And this fellow that wrote it was a physician out of Massachusetts, Harvard, all that kind of stuff. And his dad had been a physician. And I think when he wrote the book, this guy was about 80. So he was probably born in, say, 1900, 1910. And his father was a practitioner of medicine, the 1920 date is really, in some ways, like that's the first antibiotics, and some of the things around germ theory, and a lot of trauma some trauma surgery and anesthesia, like ether, was present for like the Civil War, but World War II and the discovery of antibiotics were quite a game changer in terms of therapeutic intervention. So in this book, the guy talks about his father, and when his father was practicing, the whole like, what was the measure of a good doctor? And I just find this so fascinating. He said, it wasn't that anybody really expected you to cure something or heal it. The definition was, how good were you at predicting whether the person would live or not, and how soon? So I just think that's just such a good perspective to have, because, the good doctor had good observational skills, and he was around a lot of people that were sick and injured and dying. So because of those observations, if they were astute, they got a good sense of, well, this person's going to recover. This person's going to, they would say, this person's going to die in a week. But even if you said this person's going to die in a week and you were wrong and they lived, in some ways you were a bad doctor, because because you said they were going to die in a week, people came off the field, the family gathered together. It was a big deal because they wanted to come and, say goodbye. And, it was a big, like, you stirred up all this ordeal of people saying, oh, this guy's going to die in a week. And now they lived, like, oh, you got us all riled up for no reason. So I think and so this whole thing of, and the whole scientific approach, randomized controlled trials, really started in the 1900s. The modern medical school started in the early 1900s, having rigor around what is the training methods and the training, the instructional curriculum to train a doctor. Because prior to that, it was, person to person, word of mouth, anecdotal, the whole thing of snake oil, just manipulation of people that were sick, and quackery, the worst aspects of somebody presenting themselves as a healer. And so, getting a more defined curriculum and a way to measure results and the impact of what you're doing, that's where the whole thing of evidence-based medicine and this quantification method started. And the thing I like to point out is that, so, what people died of in 1900, number one, the average life expectancy in 1900 was in 45 years old or so, because a lot of young, mothers died in childbirth, children died young. I mean, people did live to be old, say 80, but that was unusual because traumatic injuries, because people worked in the fields and, labor, and would hurt themselves, and then they get an infection and die. So here you have this scenario of what the health and wellness milieu was in 1900. And then you get these, what truly were miracles, antibiotics, better anesthetics, sterile technique, then going to ventilators, which really started, like World War II and then the Vietnam War. I mean, most of the big advances in trauma care came out of wars, unfortunately. But, so now the average life expectancy in the United States is, in the 70s someplace, approaching 80. So, but all of that focus, or the vast majority of the focus of all of that science was around these acute illnesses. So it's just causing people to live, you know, but now, and I kind of, the way I think about it from my perspective is, again, I started medical school in '77, and I saw the turn of this come like in the '90s, which was, now that you've mediated or addressed these acute problems, and now people are living that would have died, and they're living older. And so now you have this burden of chronic disease. I'll just use that word. And so some of it is because of trauma that was addressed and there's a residual dysfunction. But the other part of this that I think is that things like depression and anxiety, because people were so, you know, the things to fear were infectious disease and trauma and childbirth. And people were dying at young ages so much that, you know, to really focus on and think about, depression and anxiety, you know, those are the major burdens in the behavioral health system. You know, it was just like, I mean, people didn't even think about it. It was, you know, to be focused on, you know, so now this burden that we have of, you know, like chronic fatigue, chronic pain, even not necessarily post-traumatic, you know, chronic depression, anxiety, you know, the burdens that we're also familiar with, in some ways, that's a luxury of you know, the advancements that were made, you know, since 1900, I'll say. So, and I guess the reason I like to go through that is because I know we all have our criticisms of the allopathic system. And I, you know, and so to me, it's like that's why I like to focus on these gaps, you know. So the allopathic system was focused on the acute. Now we have this emerging chronic symptom burden. And the way the whole system was built up around addressing the acute. And I don't think the system has, I mean, the system is slowly, you know, like a big ship trying to turn, moving towards thinking about this burden of chronic symptoms, which I call the gap. So rather than categorizing it as, you know, the system, you know, because, you know, you just hear a lot of words around the system is bad, you know, the whole allopathic system, you know, there's just all the reasons to be critical. You know, it's more than just the practice, it's the financing and all of that too. But it's, to me, the gaps are opportunities. So rather than focus on the negative, the positive is the opportunities. And my feeling is that the study that you're engaged in is a hope towards those opportunities.
Can I ask a question?
Yeah.
Do you think that the reason why we're focused more on chronic now versus acute is because the treatments for the acute were treatments, they were Band-Aids and not necessarily to help heal, but to, and also to make money, like the pain, when you said chronic pain, if you look back at the history of painkillers, they really were rooted in making money. They were,
Right.
and and the research studies that they had from the beginning knew that they were as addictive as they were. They were advertising in men's magazines and things that weren't appropriate. So it wasn't necessarily about healing at something, but making money and putting a Band-Aid on acute, which now caused chronic.
So I think it partly depends on where do you decide to start your look. So if you start your look in the 80s or 90s, then I think your point probably has more validity. But if you start from the 1920s, literally, I mean, the people just thought this is miracles. I mean, it's magic. People were dying, now they're not. Which is also, in my mind, the reason it has so much residual power in it, right? It's going to be, I think this pandemic is going to be, there's going to be so many shifts that come out of this, but, the whole thing of public health and social structures, and our way of just the basic culture of, consumerism, materialism, debt, because we've created a culture that has very little resilience. And if we had more resilience in the culture, this pandemic would be a problem, but it would not be near as devastating as it is because we have a culture that it doesn't have resilience. And so where I started with that thought was, we have this system, it came for a reason. It has power to it for a reason. It's created an outcome that we're aware of. I'm trying to get good focus on it, like rather than demonize it. I'm trying to just really look at it. And I think we've been moving towards understanding the gaps and that we don't have them, but the power of the deep system and the capitalism and the patent systems, and there's so much power that behind that drives it. And so I think that incrementally there's been this evolution that's bringing in different therapies that are not patentable, that are more individualistic. Whether this crisis gives us a shift in thinking, I don't know, but I just think about it in that context.
Kind of less herd mentality and more individualism.
Yeah. And here's what I think though, is that I don't want to throw the baby out with the bathwater, because if we're in a car wreck on the freeway and got broken bones and our lung is collapsed, we want the ambulance to take us to the hospital and get all that stuff fixed, right? And so, my strong personal feeling is that, a substantial amount of the gains from that model of looking at human health, like 90% of the gains have been made, because people die. I mean, I personally am not, I don't believe, I'm not a fan of the ideas of anti-aging and trying to prolong life to hundreds, because, anyways, we don't need to go into all of that.
It's the only thing guaranteed. We're all dying.
Right. Yes. So if we kind of had the mental, so it in some ways, all of this money going into all of these this investigation and, to get people to live like 3 months longer, when if that money and focus was turned towards this gap. So what, it's like, how do we, but some of that focus change has to do with, as a society, us just realizing, okay, we're a bunch of us are living into our 80s. The natural human's time span without genetic manipulation, I don't know, all the things people are talking about, to me is around 85. It's a bell-shaped curve. If we're getting the majority of our population to 85, let's focus on having it be a better quality of life. So anyways, I think that's enough on that. But again, I go through that because of this whole thing of acute, subacute, chronic. The chronic illnesses, the reason there's been an increase in them from my point of view is partly because of the success of the acute, and partly because of the luxury of living longer, that you have this subset of conditions that probably were there before, but they've just been kind of unmasked because we're living longer. Let's see, I'm going to just go a little bit into this next thing of roles. The reason I like to just go through this of healer, I don't even, everybody has their different word for how they think of themselves if they're coming into a therapeutic relationship. Healer, a person that heals, a person skilled in a particular type of therapy. Teacher, definition, a person who helps students acquire knowledge, competence, or virtue. Part of what I like people to think about is, because many of you have been teachers, and if you're going into this role, it is a different role, because a teacher, so what does it say here? A person who helps students acquire knowledge. So in some ways, the teacher has a body of knowledge, they transmit that knowledge, but it's really up to the student to decide what to do with it. Whereas a therapeutic role, I think, has a more of an implied contract to it, which is, in the best cases, it's a mutual contract, which is the person in the, I'll just use the word patient role, is coming to the healer with a certain set of concerns. They believe the healer can assist them in understanding those concerns, and in a one-on-one sort of a way, the healer takes on the responsibility of saying, one, I think I can help you, I think I have the skills to do that, and two, I will work with you to apply that towards your goal of getting better. And so there's, I don't know, I guess it feels like, and again, I've had this discussion with lots of people, and it feels, I think there's more of a mutuality to the healer role, in an implied contract. Legally, in the physician-patient relationship, once a physician sees a patient and agrees to, engage in healing, engage in a relationship, the physician has a duty to that patient. If they engage and then remove themselves, we're supposed to give at least 30 days notice for them to find somebody else. So to just abandon a patient it's not ethical, but it does have legal ramifications. I've had patients in my practice time where they would come in with a set of issues and set of desires, and they wanted something from me, and I would tell them, I'm not the right person for you. And sometimes they would, they would want me to do something that I wasn't comfortable with. And if I was very clear on that right from the start, I would just say, I'm not going to charge you for this visit. In some cases with this copay environment, people would say to me, well, I already paid my $10 copay. I can remember several times where I just pulled out my wallet and, said, well, how much was it? $10, $20, but here's your money back. I can't, then what you want isn't what I do. and it goes back a little bit to what I said at the beginning about knowing what you want to do and not being reactive. So I think that difference between the healer and the teacher, the teacher can have people with all sorts of ideas in their class, and you're not really implying that you can take care of what their issue is. Is anybody willing to just react to that healer teacher distinction? Anybody? What do people think about that? Jenny?
I was just gonna say, I have a hard time resonating with the role healer, because I feel like a person heals themselves through our methods, and at least with my training and my knowledge, I'm not healing anyone. Maybe like a physical therapist is healing someone or somebody in that route, but I look or define myself as more of somebody who can teach healing, but not somebody who heals. I don't know if anybody else feels the same way, but
I mean, a lot of people, I don't know what word to use. I mean, that word healer, goes to the archetype. So I use it because of its deep archetypal roots. But many people, I don't know what word to use. So somebody else throw out a word or reaction. Well, if there isn't one, that's fine. But I guess I just ask you to think about what it is. One, what word you would apply to your. Well, I'm going to go before I break. I know it's getting close to where I said I'd take a break, but I want to just go to the next thing down, which says other related roles, because this is because the healer role is very connected to the priest role. I mean, the medicine man, which when I talk about, me interacting with the shaman side, I've explored that medicine man. I mean, it came out of when I practiced on the Navajo reservation and interacting with medicine men. So, the priest and the medicine man were, the ones that dealt with the afterlife. And so when somebody thought that their mortality was threatened, you would go to the priest. The technician, and I point this out because in our modern system where we have so much technical skill, like an orthopedic surgeon or a trauma surgeon, in some ways, that's the opposite of the priest, because the priest, was more the art, and the technician is more the applied science. Confidant, counselor, magician, messiah. The thing of magician, the whole thing of somebody's tricking. I mean, that's where that whole thing of, like why I talk about the placebo effect. Messiah, guru, parental attachment figure. So if you don't really think about what role you're assuming, again, people will project and put those roles onto you. And pretty soon you can be a parental attachment figure. Or people can think of you as a guru or a messiah, and certain people with certain ego states can fall into these traps as, in our roles, right? So when you enter into these therapeutic roles, and if you're good at it and people feel good about you, it's like, oh, I love you, my yoga therapist. You are my best person and I want to be around you and I feel good because I'm around you, and that whole transference. And if you're of a certain type, it's like, oh, I love being loved. And so I want, even though this person now is actually better, I want them to keep coming to see me because they're paying me money and they're telling me how much they like me. Right? So with that, that's just food for thought, basically. So it's 1:35. I said I would quit at 1:30. Let's take 5 minutes again. And then, so come back in 5 minutes and then I'll go for a bit longer. Okay, thanks. So Aaron's trying to get the video signal to work. You guys can hear me though. Ooh, there now it was really funky. It was like a green screen. Should I just go to a talking mode or?
Grab webcam real quick. Let me grab a webcam.
Should I start them, Aaron?
You go and start if you want.
Okay. Well, Aaron's trying to get a video connection, but I'll just start and you'll just hear my voice. All right. So Laura, can you give me a signal that you can hear me?
Yes, I can hear you.
Okay, thank you. All right. So I'm going to go. So I've got about another half hour, 35 minutes. On that last topic of the different roles, healer, teacher, priest, technician, guru, parental attachment figure, anybody have any reaction or thoughts they want to share about that little set of things? I'm assuming some of you have had some of those kinds of relationships though, with people attaching and expecting a lot and wanting you to be their savior.
We can see you now.
Okay, thanks.
I use the term specialist and consultant a lot.
Okay. And so a part of all of that I'm hearing, and again, I'm putting all of this stuff out there just for you guys to think about it yourself. And so again, it's kind of, I'm hearing the whole thing of you're trying to empower the person. It's acknowledging their power over themselves, trying to enhance that. Is that your intention using those words, or?
Yes, and I've also had families try and put labels on me when I'm not clear. And so if I say I'm a consultant, I'm not whatever they want to label me as.
Yeah. So do you see yourself, and somebody else can jump in, but I just wonder, I'll let me go into this thought just a little bit. What I'm going to do is move into, so I'm going to skip the part that's labeled number 2 about setting priorities from a medical perspective. I guess it really just builds on those words, build on this whole thing of, the allopathic system is most focused on the most acute things. That's really what that hierarchy demonstrates, that you're going to focus on those life-threatening, limb-threatening threats to functionality stuff first. And, the things about threats to appearance, threats to concept of self, et cetera, are down farther. And because there has tended to be enough activity higher up on that list, I think the allopathic system leaves the stuff at the bottom of the list, defers it, and that's part of what creates the gap. So that's my way of demonstrating the things I was talking about earlier. I'm going to go into this number 3, communication with others in the continuum of care, because this starts to get at the interdisciplinary things. And it also comes back to the discussion around, evidence-based and, proof and some of those types of things. This discussion basically is assuming that you're engaged with someone in a therapeutic relationship. You've established some sort of a formal or informal contract. And that while you're in that relationship, something comes up that is outside of your scope. So this starts to go into things like scope of practice. And it relates to what we were talking about earlier of what do I want to do and what I'm learning, how do I see myself applying it? All of that over time becomes, you defining your scope of practice. What kinds of people do you want to engage with? Having personal self-knowledge of roles, so the role of consultant or support person or specialist versus the role of savior and guru. So you've thought about your role, you've thought about how you want to apply these skills and the kinds of people you want to deal with. Are they old people, young people, just had babies, people with chronic conditions, people that are more just transitioning, that I'm done with them. So you've established a scope of practice for yourself and made that clear to the people you're engaging with. But so now you're engaging with that person and you realize this person has things that I can't deal with. They're either engaged with somebody else on other aspects that relate, say you're doing something alignment wise and it's related to pain, and it's related to a prior trauma. They might be dealing with a family practitioner, an internal medicine doctor, or an orthopedic surgeon, or even a physical therapist. So this starts to get to this thing of communication with those people, those other people that are collaborating or in, either a formal collaboration or an informal collaboration. Ideally, and by formal, what I mean is all parties agree that there's a collaboration. That's formal collaboration. Informal collaboration is, yeah, you're collaborating, but all the parties may not know it. This attempts to move it towards more of a formal collaboration. So this first part, this is just basically kind of like a cultural thing, like this is the culture of allopathic medicine, and I'm fairly certain this school adopts some of this format standard outline, but so this is when I'm saying format standard outline, I'm basically talking about part of this is a documentation standard, and because it's by documentation I mean a written standard, but it ends up translating into a verbal standard. And so I think different cultures, if they understand the other culture, if you're doing what you're doing and need to communicate or want to communicate with somebody in the allopathic system, I think understanding this format and how it's used is helpful. I've had people say to me before, well, why don't the allopathic folks figure out what our standard of communication is and work with us? And we can all hope for that, but because the dominant energy is in the allopathic side, I'm just working with what is. I can't change that right now. So subjective, what did the person say? You know, they're coming to you. Here's why I'm here. This is what I'm feeling. You know, symptom. You know, oftentimes symptom emotion based. You know, it's their words of why they're there to interact with you. Objective. What did the therapist directly observe? Now, this observation may include records or reports from other treatment providers. So by observation, meaning how they were carrying themselves. You know, I know you guys have a whole, or will learn a whole way of assessing alignment and limitations of range of motion and things I don't even know about. But it's what do you see? Then the assessment is the characterization of the situation. And I make the point here that in the field you're training in, you really should avoid making a diagnosis. You know, it's some kind of a summary of the way you're seeing the subjective and the objective. You know, even if somebody, you know, so this is a point to think about. You know, if somebody comes to you and they say, I have such and such a diagnosis. You know, a diagnosis in some ways is a label. They may, you know, the thing of it is, you know, so they may say that to you because they've done an internet search and they've looked at all the symptoms and they say, they attach that label to themselves. I personally, you know, if somebody comes in and it's the first time I met them and they tell me I have this diagnosis, unless it's just really obvious that I can just see, you know, I'm paralyzed on my left side. I've had a stroke, but otherwise I try to be like, you know, you're telling me this, I accept that you're telling me this, but I'm not going to accept that label for you until I do my own assessment, because otherwise they may have that label. And if I just go down that path, I might miss a whole other side of what might actually be causing their issue. So not accepting the labels, I think, is just good practitioner practice. But the other piece is, you know, if you put certain of these things, you know, like in your assessment, if you just put this person has this diagnosis, you know, one, it potentially, even if you characterize based on what they're telling me, that won't be a licensing issue. You know, like practicing medicine without a license. But if you engage with the person, you know, so now let's just, for example's sake, say somebody comes in and they tell you, I've got rheumatoid arthritis, just for example, that label, and you know, they have sore joints, and you know, so they're presenting to you because they have sore joints and they want to improve that, and now you've worked with them and they're not getting better, or you feel like they're even getting worse, and so you want to engage with, say they're seeing an internal medicine doc or family practice doc, and you engage in a means of, you figure out a means of having a dialogue with that person, and you immediately say, you know, this person with rheumatoid arthritis that I'm seeing, that blah, blah, blah. And if they say, you know, that person, we've done all the evaluation and workup and lab, they don't fit the criteria for rheumatoid arthritis. And I don't know that that's really the best example, but I do know that, you know, it creates a bit of a credibility gap if you're too accepting of these labels and, you know, approach somebody else and, you know, just assume that that label is correct. And then they're like, well, this person is, I'm not sure about this person because they don't even know what's going on, kind of thing. You know, so I just think, the whole thing of labels and diagnoses, I'm basically saying to be cautious with it. And then the final is plan of care. What are the agreed upon next steps? And so at this point, I mean, this is why, this is building on the thing of therapeutic relationship and being different than a teacher in my mind, you know, like a yoga teacher where you're teaching a class, is you're really trying to define and agreed upon, this is what's happening, this is what you expect of me, this is what I think I can do, this is the plan we have outlined, you know, and part of the plan should be, you know, that engagement of the person that you're is in front of you. And when you guys talk, you know, if you're empowering and working with the empowerment model, you know, maybe some of this is just self-evident, but I think that, and this goes to the whole thing of transference and guru-ness, you know, if you're really clear about what's the engagement, what have we agreed to, what do we think is going on, what do I agreed to, what am I trying to accomplish, and then you're having a series, and you know, and even saying, you know, going to do this weekly for 3 months or whatever you want to say, and reassess the effectiveness at that time. I think, again, I think that's good practice because it tends to avoid the, again, that trap of people attaching, you know, if you have seen somebody for weekly for 2 years and the assessment and plan is exactly the same as it was when you first started seeing them, you know, that's, you know, I'm exaggerating to make a point, you know, that's when you should start to think about what's really happening here. And again, a good practice of saying, is what I'm doing the right thing for this person? Is there somebody else with different skills that perhaps might be somebody to, you know, to be an addition to what I'm doing, or just what I'm doing with this person is just not working.
Could I ask, could a long-term goal be that you're there to improve life and not necessarily treat something? Because
Well,
that could be a long-term being something more of improving life on someone who has cancer. You're like, you're not going to cure the cancer, but you might be working with them for 5 years.
and I think that's totally acceptable. I think it just goes to, I mean, this is why I start with the whole thing of health and wellness and being clear about what you're trying to do. And, you know, and those definitions that seem to be just having goals of restoring to health or wellness, which kind of imply absence of disease or injury. So that's, I mean, that's exactly what the point you're making is exactly why I start with those words. But as long as both parties are clear, then I think it's a fair and ethical relationship. So that, and that's part of my point on this. Does anybody else want to input on that? I'm gonna, otherwise I'll move on to my next step. So I'm not trying to tell you what this should be and what the goals should be. I'm just pointing out to have a relatively clear goal. So that, which leads to the whole thing of where we were talking about evidence and, you know, evidence and, measurement and quantification. In order to, so if you're only working in your own space, doing your own thing, the thing that I'm going to say next, I think doesn't make any difference. To the extent that but that scenario that I just laid out doesn't even happen because you're in the community, you're talking with people. A part of what I think having some discipline around at least your documentation process and being clear of what you're trying to do is that if people are unclear, and because lack of clarity as you're talking to the community about what you're doing or talking to people with other disciplines and other tradition backgrounds, you can get, the question of, is this person, do they have discipline, or are they somebody that I just think doesn't have it together? And, I've said before in teaching, that I think that the yoga therapist, as you go through your training, to kind of keep each other, like here's our set of principles, and if somebody goes out and does, again, the whole snake oil, like the MD piece, lots of variance and a lot of scammery, getting a more disciplined, here's what the curriculum is, here's how we do things, here's how we collect evidence, etc. It put the MD profession on a more credible, trustworthy track. And I think as you're all establishing this field in a more visible way in the community, I'd say, and if you're start talking with and dialoguing with other disciplines, a sense of professionalism and is important. And the reason I give some of this format stuff is because, if you're communicating to someone and trying to refer them, this format that I've outlined is what we teach medical students. And I've taught second and third and fourth. I've taught a lot of medical students, and particularly in the second and third years is when they're kind of learning some of this language stuff. And me just describing what I just described, I'm sure it's just like, oh, that's straightforward and it makes good sense. But applying that to talking to somebody and doing it in a concise way. These are, if you get this down and learn it, it's just like, because you're talking to other people that are busy, you're trying to get them to collaborate. You might be a phone call and it's like, I have this person I'm seeing, such and such a name, they already see you, is that true? Okay, then the S, here's what they've told me, this is why they've engaged me. The O, these are the records I've seen, or these are the things that I've observed. And the A, I thought we could work on this together. The client and I agreed to it, and this was our plan. We've been doing this for a month, 3 months on a weekly, and I see these things improving, but these other things I'm worried about. She's asked me to communicate, he or she's asked me to communicate this to you, and what do you think? What do you know? So having this format to be fairly concise and just to organize your thoughts rather than kind of wander all over. And I say that because I know that taking people through second, third year medical students, they struggle with this. So, they'll just be all over, the last things are first and the first things are last, and you're trying to figure out what they're telling you, and it's not making any sense. So, and then the second piece of that, so a part of this is to, just be able to communicate. The second part of it is, if you're going to try to create some evidence bases, this is sort of your way of, these are, in some ways, these are like data fields. And if you have certain types of things you do, and if you wanted to keep a database, it's like, I have these 10 people that I'm seeing for this type of thing that I've categorized in this way, and I'm applying this sort of a protocol, and these 10 people over time, all seem to get better with that in this kind of period of time. So it becomes a way to, for you to know for yourself, how are the things you're doing working, and then to, potentially talk to your peers, or the school could put a database together and you all could, aggregate these kinds of things in a way that your community continues to improve their modalities. And then I'm going to just quickly go into this number 4, and then I'll open it up for other feedback. But this readiness for change model, and I think this, if you haven't, I'm pretty sure that the school has this as a part of the teaching. If you do a Google search on readiness for change models, and the Prochaska model is kind of a standard model, and it's basically like a assessment questionnaire that, based on the answers, puts people into these various categories that you'll see below there. And this is, I don't know, I mean, it's been around for a while now, but when I was in training, we weren't taught this, but I really think it's a nice, at least to be aware of it and to apply it perhaps a little bit, that if somebody's in the pre-contemplative state, that means they're in denial. And if you think you're going to be able to help that person very much, the thought behind the Prochaska model is knowing where somebody is in their readiness to change, that you modify and use different tools for different scenarios. So somebody might come in saying, I have stiffness in these 2 joints. And if you just immediately go to stiffness in these 2 joints means I do this, and you haven't assessed their readiness for change, you're likely to get not a good result by treating everybody the same. So this is really, I mean, that's self-evident when I say it that way, but by actually having a little bit of an objective assessment tool, to try to, because the best use of this tool is assessing it using the proper techniques to move people into where they're moving from preparation to action, because the therapeutic effect is most effective when people are ready to take action, and they understand and have admitted, yes, I have an issue, I understand the issue. They make a plan that they think they can execute. They work with you to execute the plan and move towards consolidating those gains. So, I know that I've thrown a lot at you in a short time, and I know that you're early on in this portion of your training. What I'm hoping is that that I've stimulated some thought for you that makes some sense today and maybe get you to think about something immediately. The other thing that I hope, though, is that as you're in your training, that something will happen and you'll go, oh, I remember that doctor talking about this, and oh, what did he say? And maybe you can go back to your notes, or it stimulates conversation between you and the teachers here and between you and your peers about how you're going to advance your learning and how you're going to advance the credibility of your profession. Okay, so it's almost 2:15. Aaron wanted me to be done about 2:15 to move to the next thing. Any other reactions to what I've said?
I just wanted to thank you for keeping it very engaging and stimulating. Thank you very much.
Appreciate that. It's particularly hard in this video. I mean, usually in the room, I can kind of see if somebody seems to be not understanding or whatever, and try to bring them in. But thanks for that feedback. I appreciate it. Okay, well, I hope you guys have success. I'm a real believer in what you're trying to do and what you're trying to learn. I hope you can find a scope of practice that is satisfying to you, that makes you feel good about applying your knowledge, and that you don't just get into a reactionary cycle of just doing the things that people ask you to do. Because that can get to a dissatisfying place. Okay, with that, I'm gonna mute, and Aaron, I'm sure, will be putting up a timer, and I don't know what he's got up next, so I'm not a good source of further information. All right, I'm gonna mute you guys. Thanks a lot.
Thank you.
Yep, bye-bye. Where is that?